Hello, welcome back, everybody, for the second lecture on the mini course on the basic knowledge and the beauty of it. I feel like I'm in charge of a beauty parlor by the end of the week. I'm very grateful for you coming. The speaker today is Professor Conrad Verstraete from Ghent, Belgium. Really needs no introduction except to tell you he's one of the giants of MSK radiology in Europe. And he is going to talk to us about tumoral and pseudotumoural musculoskeletal lesions. He tells me there's going to be some interactivity, so those of you who'd like to interact with him, please go ahead. And just before I ask Conrad to give his lecture, can I also remind you that all the speakers have compiled a series of questions which you can access in two ways. The first is to go up the classroom, the EPOS classroom, on the first level, where you'll find the questions related to the lecture yesterday, today, and the future lectures for the rest of the week. But failing that, they're also available on assessment.myesr.org online afterwards. So, Conrad, can I ask you please to give the talk on tumor and pseudotumoural lesions?
Thank you, Victor. So this is session on tumoral and pseudotumoural musculoskeletal lesions, and it's quite a huge task. So the learning objective is that you should become familiar. You should become familiar with the imaging characteristics and the imaging modalities to assess bone and soft tissue tumors. We start with the bone tumors. The task of the radiologist is to detect the lesion, to characterize the lesion, to provide a diagnosis, to stage the lesion, and to monitor therapy in malignant lesions. You can start with a plain radiography, and this is still the first choice imaging method for detection of a lesion. And you can easily see a bone-forming tumor in the distal femur of this teenager, so it produces osteoid matrix, and there is a destruction of the cortex on the posterior side, so you can make the diagnosis of an osteosarcoma. Brain radiography is less sensitive in complex areas, such as the pelvis, or the spine, or the skull base. There you have superposition. And usually we will make an MRI for staging and defining the local extent of the tumor. In some cases, you need CT scan to better see the matrix of the lesion, and especially to find the nidus of an osteoid osteoma. CT is a very good technique. So, plain radiography is the first choice imaging method, but in this teenager, I wonder if any one of you is seeing a tumor. That's a problem of plain radiography. It is less sensitive in the early phase when there is not enough bone destruction. So, this was a Ewing sarcoma invading the bone and the soft tissues. And only if you looked carefully, maybe you should have seen this little soft tissue mass. So cross-sectional imaging is certainly a technique which is useful for finding the lesion. So we detect a lesion, now we have to make a diagnosis. How can we make the diagnosis? First of all, the age is very important. Let's look at this young patient, 11 years old, with a lesion in the femur. On T2, we see a soft tissue extension. There is a mass. So it's a malignant lesion, and at this age, only Ewing sarcoma and osteosarcoma can be the diagnosis. Chondrosarcoma and other tumors occur only in adults at older ages. So we will also look at the location within the skeleton. So we have a diaphyseal lesion, and when we look in the proximal femur, only the malignant Ewing sarcoma is mentioned. Other tumors have other preferential locations. We not only look at the age and the location within the bone, but we also look at the location, is it diaphyseal, is it metaphyseal, or is it in the epiphysis? And here we see again that the Ewing sarcoma is occurring in the diaphysis in the child. Osteosarcoma preferentially occurs in the metaphyseal region. And when you have an epiphyseal lesion in a child or a young adult, you should think of a chondroblastoma or an infection. And in an adult, you should think about a giant cell tumor, an infection, or a geode. So the location within the bone is important. You also have to look at the size. You have to determine the matrix, look at the reaction of the surrounding bone, and to look at the pattern and the margins of bone destruction. So we will first look at the pattern of bone destruction, where you can see whether the lesion is aggressive and you can get an idea on the growth rate of the lesion. So geographic is slowly growing, certainly when there is a sclerotic reaction, and when there is no sclerotic reaction, it is already more aggressive. If you see a moth-eaten bone destruction with large osteolytic areas in the bone and in the cortex, or permeative bone destruction with smaller lytic areas, you should think of an aggressive lesion, and this does not mean malignant, it means aggressive. And so we often have difficulties to differentiate a Ewing sarcoma from osteomyelitis. So let's have a look at this case. This is a normal cortical bone in the metacarpal, and here we have a permeative bone destruction, very small lytic areas, and there is a nice periosteal reaction. So this is permeative bone destruction. Is it osteomyelitis or Ewing? Well, we see a soft tissue mass extending into the soft tissues and the muscles. This was a Ewing sarcoma again. Look at this moth-eaten bone destruction. Many lytic areas in the humerus, a faint periosteal reaction, some sclerosis, low signal intensity on T1, high signal intensity on T2, question, osteomyelitis or Ewing. Well, you should look at the soft tissue mass. If this would be a Ewing sarcoma, you should have a large soft tissue mass. It's absent. There is also no sharp delineation, and this is all in favor of osteomyelitis. So absence of soft tissue mass and no sharp delineation is in favor of osteomyelitis. We look at periosteal reaction, and you know the typical solid periosteal reaction, but now we have a focus on aggressive and very aggressive periosteal reaction. You all know the lamellated and onion skin periosteal reaction, which is often seen in Ewing, but which also can be seen in osteomyelitis. And here we have hair on end and sunburst periosteal reaction with ossification in the soft tissues. This is typical for osteosarcoma. Okay, the next point we have to look at is the matrix of the lesion, and we will start with the osseous matrix. How does it look like? So now we become a little bit interactive, and you have to guess the name of the lesion. This lesion is a benign lesion. It consists of compact bone, can occur in any bone. You see it every day. It's homogeneous and dense, and is typically continuous with the trabecular bone. You will see the continuity. So the name of the lesion is anostoma, bone islet. Very easy. The next lesion consists of compact bone. It's very dense and frequently occurs in the paranasal sinus. The name of this lesion is a osteoma. So really compact bone. Another lesion which produces osteoid matrix, it's a benign bone tumor. It's painful, especially at night. It's small. There is a nidus, which you can see here and there, and it makes osteoid. There is always extensive reactive sclerosis, and you need CT to see the nidus very good. The name is osteoid osteoma. Here you see the osteoid osteoma, and on MRI you will always see extensive edema in the bone marrow and also a active periosteal reaction with edema. So to find the nidus of an osteoid osteoma in the spine, for instance, you need CT scan, and you will see the nidus with osteoid formation and the reactive sclerosis. The next lesion is also osteoid producing. It occurs in children and young adults. It's painful again and larger than 2 centimeters. It's frequent in the spine, and patients can have an antalgic scoliosis. On MRI, you see edema surrounding the lesion, but the problem with MRI is that you cannot assess the matrix. You don't see the matrix. So in this case, we need again a CT scan to see the matrix, and we see again there is osteoid formation. So the name of this lesion is an osteoblastoma, which is a giant osteoid osteoma. Next lesion, which is malignant lesion, occurs in teenagers. It's a painful mass, frequently in the femur and tibia, mainly in the metaphyseal region, with malignant bone formation, so it's more white, and you have also malignant bone formation outside the bone. This is a conventional osteosarcoma. Osteosarcoma often has a periosteal reaction, and here we have a special type of periosteal reaction where you only see one piece of periosteal reaction and the tumor is growing into the soft tissues and is destructing the periosteal reaction. This is called Codman's triangle. And in this case below, you see typically hair on end and sunburst periosteal reaction. For these malignant tumors, MRI is the best technique to see the bone marrow invasion and to see the invasion into the soft tissues. So we have seen the age, the location within the skeleton, the reaction and the margins of the lesion. We look now at the matrix. We started with the osseous matrix and we will continue with the cartilaginous matrix. Here we have typical radiographical appearance with fine stippled calcifications, or they can be flocculent or popcorn-like calcifications, and sometimes you will see rings and arcs. These are typical for cartilaginous tumors. Let's start with the first one. It's a benign lesion, frequently occurs in the long bones, incidental finding. Sometimes patients present with pain and they are consisting of calcified cartilage. So the name is enchondroma. Enchondroma on MRI will have a low signal intensity on T1, high signal intensity on T2, and you see the hyaline nodules. And if you look very well, you will see black calcifications, which are black on T1 and T2. When you use gadolinium, you will have a septal enhancement, which is due to the fact that the fibrovascular tissue is between the non-enhancing hyaline nodules. Another case, here we have a lesion in the hand, presenting as a growing mass, or sometimes with a pathological fracture. It can present with calcifications or sometimes without calcifications. The name is again enchondroma. But the big question is always, is it an enchondroma or is it a chondrosarcoma? So on conventional X-ray and MRI, this is really a difficult question. And we use dynamic contrast enhanced MRI, where we look at a region of interest at the artery in red, the muscle in blue, and the whole lesion or the fastest enhancing area in yellow. And in this case, we see that the perfusion is lower than muscle tissue. This was an enchondroma. We have another patient with stippled calcifications in the fibula and a septal enhancement. And when we perform dynamic MRI, we see that the enhancement of the whole lesion and the fastest enhancing area is more than the muscle tissue. So we did a study on that, and we tried to find a criteria to differentiate. So we take the muscle as reference, and we look at the enhancement of the tumor. When you have a steep slope of more than 4.5, and when the tumor enhances more than 2 times the muscle, you will find all chondrosarcomas, but there is a problem. You will have 37% of highly vascular enchondromas, which will also be referred for biopsy. So maybe you can put the limit higher, up to 3 times the enhancement of the muscle. Then you will have less false positive enchondromas, highly vascular, but you will miss a few chondrosarcomas. So the truth is in between, and you should look for other signs of malignancy, which are endosteal scalloping, cortical remodeling, cortical thickening, and periosteal reaction, soft tissue mass, and peritumoral soft tissue edema, although these signs are not so frequent. So this can help you to make the differential between these two tumors. Let's go on. Here I have a lytic epiphyseal lesion in a teenager. It's a thin sclerotic delineation or sometimes no delineation. There is a transition zone, and it frequently occurs in the epiphysis, in the femur, tibia, or humerus. So the name of this lesion is a chondroblastoma, typically young patients. On MRI, chondroblastomas will be surrounded by a lot of bone marrow edema, and if it's near the cortex, you will even see edema in the soft tissues. So epiphyseal lesion in a teenager, think of chondroblastoma. This is a difficult one. It's an extremely rare lesion. It's benign, expansile, eccentric lytic lesion with well-defined sclerotic margins, a thin, elevated cortex, and this is important because maybe some of you think of a non-ossifying fibroma. Non-ossifying fibroma will not have a thin and elevated cortex, so this is typical. You see ridges and grooves and a soap bubble appearance, and it frequently occurs around the knee, femur, tibia, fibula, and it contains fibrocartilaginous tissue. The name is a chondromyxoid fibroma, very rare lesion. So we have seen osseous matrix, cartilaginous matrix, and now we have both together. Here we have a benign lesion, slowly growing, with an osseous base and a cartilaginous cap. It's less than 2 to 3 centimeters. You see it growing, and this is an osteocartilaginous exostosis. It should stop growing at the age of 21. Sometimes it occurs as an autosomal dominant disease in hereditary multiple exostosis, and 5% of these lesions will become malignant, and you should measure the cartilaginous cap, which should be less than 2 to 3 centimeters. So how to measure it? Just perpendicular to the bone up to the surface of the lesion, and that should be less than 2 to 3 centimeters. Now we continue with the fibrous matrix. Here we have a benign tumor which has a typical ground glass appearance, smoky, hazy matrix. The name of that lesion is fibrous dysplasia. And fibrous dysplasia can occur in the whole skeleton. It's frequent in long bones and craniofacial bones. And you will often have a focal thinning of the cortex, and it's often an incidental finding, like here in this fibrous dysplasia of the rib. And this patient has a lot of fibrous dysplasia in the humerus, but also in the radius and ulna. So that is a polyostotic fibrous dysplasia, which is often diagnosed before the age of 10. That's only 20% of patients. 80% of fibrous dysplasia is monostotic, and this diagnosis is usually made before the age of 30. A fibrous dysplasia will have weakening of the bone and sometimes pathological fractures. It's not very strong, this tumor. So look at this nice sheep and the shepherd's crook, and you see that the femur, which is not strong enough due to fibrous dysplasia, resembles this shepherd's crook. When you do MRI of the skull, you will sometimes see strange lesions in the bone, and it's difficult to make the diagnosis of fibrous dysplasia on MRI. So I recommend to do the CT scan and to look at this ground glass appearance, which is better recognized on CT. Fibrous dysplasia here in this patient, in the iliac bone and in the femur, we will examine it on MRI. And what are the characteristics of fibrous dysplasia on MRI? It's a low signal intensity on T1, and when you use gadolinium, it has an early and fast enhancement. So this is not a sign of malignancy, it's normal. Fibrous dysplasia is highly vascular tumor. So here you see again the enhancing areas, which is normal, and fibrous dysplasia can have cystic components with high signal intensity on T2 and non-enhancing on gadolinium. So this is typical for fibrous dysplasia. We continue with this lesion. It's benign, incidental finding, second decade, eccentric subcortical metaphyseal lesion, multiloculated with central lucency and scallop sclerotic margin. You all know the name and you see it very frequently. It's a non-ossifying fibroma, histiocytic fibroma. Important, please tell your colleagues it's a don't touch lesion, no biopsy is required, and do no further imaging. It's a waste of money. It will disappear spontaneously, it will regress, and you will see fainting away the lesion, so the central lucency will disappear at the age of 20 and older. Sometimes we have a pathological fracture in a non-ossifying fibroma. The malignant fibrous tumors are very rare. It's a fibrosarcoma and malignant fibrous histiocytoma, which are aggressive lytic lesions with periosteal reaction and extension into the soft tissues. And then we have the fatty matrix. Here you see a benign tumor of mature fat cells. It frequently occurs in the calcaneus, and you should make the differentiation with a solitary bone cyst. So you perform an MRI, and you will see the high signal intensity on D1. So this is an intraosseous lipoma, and sometimes there is a central calcification. But there, besides osseous, cartilaginous, fibrous, and fatty matrix, there's a lot of other primary bone tumors. So we first go to the cystic blood spaces and vascular tumors. Have a look at this one. It's a fluid-filled cavity lined by a thin membrane, occurs between 5 and 20 years old, but can persist later. It's often asymptomatic, but can present with a pathological fracture. So we see a well-defined lytic area with a thin sclerotic margin. This lesion is a unicameral or simple bone cyst. Simple bone cyst presents as a lytic area on X-ray and CT, very high signal intensity on T2, dark and homogeneous on T1, and you have a typical peripheral enhancement, no enhancement of the fluid. The next lesion is a solitary expansile and erosive lesion, painful, causes local swelling, and it can occur in any bone, but frequently in a long bone and the posterior part of the spinal. It can occur at any age, but many are discovered before the age of 20. So the name of this lesion is an aneurysmal bone cyst. How can we make the final diagnosis and differentiate it from a simple bone cyst? You need MRI. I give an example of a girl of 13 presenting with neck pain and acute paresis of the right hand and leg. So we see a fluid-filled sponge with fibrous septa, and best seen on T2 are the fluid levels. You can see these fluid levels on T1 and after gadolinium, but I recommend to use the T2 to see that. And you have to window very carefully. The next tumor also consists of vascular spaces. It's a benign lesion, and it contains vascular spaces and fatty components. 50% of these lesions occur in the vertebral bodies, and they have a polka dot pattern. 20% occur in the calvarium and the rest in long bones. The peak incidence is above 50 years of age, and the name of this lesion, you all know, it's a hemangioma. You see it every week. There are two types. One with a vascular predominance, which is not so frequent, has a low signal intensity on T1. After gadolinium, it enhances, and it has a high signal intensity on T2. And on dynamic MRI, it has a high perfusion. So this is the hemangioma with vascular predominance. There is another type with more fatty predominance. And this one has a high signal intensity on T1 and a lower signal intensity, but still with some white spots within it, which are composed of vascular components. So this is the more fatty predominant hemangioma. Here's a nice example of a hemangioma of the calvarium, which looks like radiating wheel spokes, and the lesion can be slightly expansile and compress the brain. Okay, let's continue with special cell types. The first one is a locally aggressive metaepiphyseal lesion. in an adult. And it's eccentrically located, frequently in the femur, radius, and proximal tibia. It's slowly progressive, often with pain, and can present with a soft tissue mass. Sometimes there is a pathological fracture, like in this case. What's the name of the lesion? It is a giant cell tumor of bone, osteoclastoma. Osteoclastoma may expand into the soft tissues, and you need MRI to see the soft tissue expansion, and there will be a lot of edema as a reaction to that. These tumors on dynamic contrast enhanced MRI will have a typical high first pass, a very short plateau phase, and a very early washout within the first 2 minutes after enhancement. So typical on dynamic MRI, giant cell tumor of bone. Next one is a Ewing sarcoma, which is a tumor which mainly affects children below 20, preferentially in the long bones, and you have swelling of weeks or months of duration. So you always look for the soft tissue mass in a Ewing sarcoma. In the early phase, it's hardly visible on plain radiography. The next lesion is composed of histiocytes. And here we see a lytic lesion in the diaphysis of the femur in a child between 5 and 10 years, presenting with pain, swelling, tenderness. This lesion frequently occurs in the long bones, but also likes the spine and the pelvis. And it's composed of Langerhans cells. So the name of this lesion is eosinophilic granuloma. And on T1, you should be carefully look at the signal intensity of the lesion and compare it with muscle. If you do the windowing very good, you will see this eosinophilic substance is a little bit higher than muscle tissue. It contains more fatty. So that's a clue for eosinophilic granuloma. On T2, there will often be edema. So it's an aggressive lesion, but it's benign. So you look for the edema, and there is a lot of enhancement. Next lesion is an epithelial lesion. It's not frequent. And the typical location of this lesion is the anterior cortex of the tibia, where you will see a lot of well-circumscribed lytic lesions. If you have a person in the first decade, it will be a benign osteofibrous dysplasia, and in adults, you should think of the malignant adamantinoma. It's a low-grade malignant lesion, which can also present with a pathological fracture. And the last lesion on bones is this one. It's a malignant osteolytic tumor arising from notochordal cells, frequently located in the skull base, upper C-spine or sacrum, with a low signal intensity on T1 and a high signal intensity on T2. The name is a chordoma. So we have to do the staging of the lesion, and you should always perform a longitudinal imaging looking for skip metastasis. And only afterwards you should do the local staging. So here we have a T1 to look for bone marrow extension, and the other axial images, including gadolinium, are necessary to see the soft tissue extension. Remind, always first do the MR before biopsy. And why do we need to do that? Because we want to find areas with representative and viable tumor. We want to avoid necrosis and hemorrhagic areas when we want to do the biopsy. We can say to the surgeon where to do the biopsy, and he should go to the most enhancing area. And we don't like a biopsy because after biopsy there is a lot of edema, hemorrhage, and granulation tissue, which make interpretation difficult. Now we have to do the monitoring of therapy. And when we have an osteosarcoma or a Ewing sarcoma, we see the patient at day 1, and we will perform a dynamic contrast enhanced MRI showing very high vascularity and perfusion. And then we see the patient after 3 months of neoadjuvant chemotherapy, and you will see a lower enhancement, slow enhancement, and the first pass is very slow. So this is a good response. You need dynamic MRI to monitor therapy. You also need other techniques to see the evaluation of the prosthesis. We will use conventional radiography. You have to detect local recurrence, and you have to detect distant metastasis. using CT scan of the lungs. Evaluation of the prosthesis is usually done with X-ray, showing you a fracture, migration of the prosthesis, and loosening eventually with infection. If you want to detect a recurrent malignant tumor and there is a prosthesis and metal, you need to do ultrasound to detect a recurrent mass lesion, which will be hypervascular. And if you find a hypervascular lesion which is far away from the metallic artifacts, you can do dynamic contrast enhanced MRI, and recurrent tumor will have a steep slope and a high enhancement compared to muscle. On the other hand, if you see a white mass lesion with slower enhancement than a muscle, it is just reactive tissue. So this was the task of the radiologist: detect a lesion, diagnosis, staging, and monitoring of therapy. So for bone tumors, X-ray, CT, and MRI are the best techniques, and MRI is the best technique for staging, biopsy planning, and post-treatment follow-up. Now we go to the second part of the lecture, where I have contributions from Professor De Schepper, who deceased last year, and from Philip van Hoenacker. So our task for soft tissues is just the same. Detect a lesion, give it a name, do the staging and monitoring of therapy. So for soft tissue tumors, we will start with ultrasound. And with ultrasound, you can differentiate a cyst from a solid mass. And sometimes you can make a specific diagnosis when you see larger vascular spaces and you can compress these spaces and you see slow or high flow. Sometimes with phlebolytics and an acoustic shadow, you can make the specific diagnosis of a hemangioma. Another lesion which can make diagnosis with ultrasound is this one. You have a hypoechoic around to oval mass and you see a continuation with a nerve, then you can make the diagnosis of a nerve sheath tumor. Be careful with this diagnosis. Many of you will say that they have seen a soft tissue lipoma. Well, in fact, don't take the risk to make a wrong diagnosis of a lipoma, and sometimes it's a soft tissue sarcoma. So this study by Inampudi and Van Holsbeek's team has shown that sonography demonstrates low accuracy in the diagnosis of soft tissue lipomas, because lipomas can be hypoechoic or hyperechoic. So the recommendation is non-cystic lesion below the fascia. Don't tell it's a lipoma. First do MRI. Otherwise, the surgeon will do a biopsy thinking that he will find a lipoma, and then he's saying, oops, it's not a lipoma. So then you have a oops lesion. Good. So first you do ultrasound. You can differentiate a cyst from a solid mass. Be careful with lipoma. And then you do MRI. And some tumors, mainly benign tumors, have specific signs, and you can give the diagnosis. Specificity for malignant soft tissues is lower. And when you have a malignant lesion, you will need CT and scintigraphy. So we will try to make the diagnosis, first starting with the age, sex, and preferential location. These are two important articles which you should find, written by Kransdorff, AGR 1995. He has two articles, one on malignant soft tissue tumors in a large population and one on benign tumors. And this article consists of a lot of tables. So if you have a child between 0 and 5 and it has a mass in the hand or wrist, the most frequent will be a hemangioma. And in an adult, the most frequent lesion will be giant cell tumor of tendon sheath. When the lesion occurs in the lower extremity, it's in a child 0 to 5 years, it will probably most frequently be a granuloma annulare. And in an adult, it will most frequently be a lipoma. And they also have tables for malignant lesions. So for instance, a hand and wrist lesion in a young child will be fibro or angiosarcoma, and a lesion in the hand In an older person will be malignant fibrous histiocytoma or leiomyosarcoma. So just looking at the location and the age and these tables gives you an idea of the name of the lesion. So here we have the age. In children, the most frequent benign lesions are hemangioma, fibrous hamartoma, granuloma annulare, and lipoblastoma, and the malignant is fibrosarcoma, whereas in adults, lipoma, liposarcoma, and myxofibrosarcoma are the most frequent lesions. Example, here we have a man of 77 with a lucent lesion here in the thigh. It's completely lucent, and on T1 we have a homogeneous high signal intensity, completely dark on FATSAT T2, so this is easy diagnosis of a lipoma. But be careful, don't tell on ultrasound that this is a lipoma. Here we have a lesion with high signal intensity and low signal intensity, and it does enhance quite a lot. And on T2, we have a very bright signal and a lot of enhancement after gadolinium. This is not a lipoma, but a liposarcoma. Okay, so we have the age, but we can also look at preferential location. And this type of tumor with low signal intensity on T1 and T2 occurs frequently in the rectus abdominis muscle in young women, and the name of the lesion is abdominal desmoid or musculoaponeurotic fibromatosis. This lesion preferentially occurs deeply under the scapula and the serratus anterior muscle. So when we look at it, you have fatty strands and elastic fibers on both sides. The name of the lesion is elastofibroma dorsi. The next lesion is a lesion which occurs along the veins. And we see a lesion which is a lot of enhancing. There are a few necrotic areas indicating fast growth. The name of the lesion is a leiomyosarcoma, just by location. When you see a lesion along the course of a nerve, here the sciatic nerve, a large lesion enhancing and necrotic areas, you should think of a malignant peripheral nerve sheath tumor in the sciatic nerve. And when we look on T2, this patient is well known with neurofibromatosis type 1. Other location is along the course of a nerve, and you see a lesion with nerve fibers, but also with fatty tissue, high signal intensity on T1. The name is fibrolipomatous hamartoma, a lipomatosis of the nerve. And when you have an adult with a lesion in the finger, which has low signal intensity on T1 and low signal intensity on T2, you can make the diagnosis of a giant cell tumor of tendon sheath. A patient presents with a low signal intensity mass, which does enhance quite a lot after gadolinium, is having some impression of the bone, and when you press on the lesion, your patient jumps. It's very painful. The name of this lesion is a typical glomus tumor. This is another one with preferential location in the elbow, here just above the elbow, sometimes in the axilla or in the neck. And you will do ultrasound and you will see a enlarged and hyperemic lymph node. So think of cat scratch disease. It's not a real tumor, but a pseudotumor. So we can make the diagnosis using age, sex, preferential location. Now we look at multiplicity and morphological signs. Neurofibromatosis will have fusiform or worm-like elongated masses along the course here of the cervical plexus and the intercostal nerves. This is typical neurofibromatosis, high signal intensity on T2. Xanthomas are not frequent due to hypercholesterolemia, and you will find them in the plexus of the brain in combination with low signal intensity masses in the Achilles tendon. The name of this rare disease is cerebrotendinous xanthomatosis with typical multiplicity. Multiplicity, think of any soft tissue sarcoma, but when you have a combination of soft tissue lesions with bone lesions, think of metastasis and not of a primary soft tissue sarcoma. This is more frequent. And now we continue with morphology. specific morphology which can help you make the diagnosis. First of all, the fluid-fluid levels. Fluid-fluid levels occur in benign and malignant lesions, but when they extend for more than 2/3 of the volume of the lesion, it's probably a benign lesion. And this is frequent in cavernous hemangioma. When it's less than 2/3 of the lesion, you should think of synovial sarcoma or another high-grade sarcoma. So here we have a nice fluid-fluid level, a lesion with high signal intensity in the subcutaneous tissue, which is a classic cavernous hemangioma. In this lesion, we have less than 50% of fluid-fluid levels, aggressive lesion, which proved to be synovial sarcoma. And here we have a large lesion which is destructing the rib. It occurs along the course of the intercostal nerve with a small fluid-fluid level due to necrosis, was a malignant peripheral nerve sheath tumor. I know you are hungry. Well, I have specially for you a bag of worms. So when you see this in a T2 lesion, you should think of a hemangioma. But I see you don't like a bag of worms, so I have a bunch of grapes for you. So here you see a bunch of grapes, high signal intensity with some phlebolytes. So that's typical for a hemangioma. And you should look for fatty strands, which are also typical for cavernous hemangioma. And for the Italians, we have the lasagna aspect. Lasagna is present when you have some fatty strands, and in between these fatty strands, you see elastic tissue, and this is again the nice elastofibroma dorsi. And for the vegetarians, I have broccoli. So here you see a lipoma arborescens, and that is in fact a synovial lipoma. So that's the typical broccoli sign. Good. A fascicular sign is seen in the lipomatosis of the nerve. I have seen this case already. So you see fatty strands and nervous strands, and this is the lipomatosis of the nerve. A target sign is not so frequent and can be seen in a schwannoma or neurofibroma with a low signal intensity area on T2, which is enhancing after gadolinium. So you can use the shape and a pattern to make a diagnosis. Sometimes we have intralesional calcifications which can help us. And here I have an X-ray with a calcification, and on MRI it's an A-specific lesion. I just can say it's an aggressive lesion which is destructing the bone, which is invading the soft tissues, typical low signal intensity T1, high signal intensity T2, and enhancing. But this calcification helps you to make the diagnosis of a synovial sarcoma. So think of synovial sarcoma when you have calcifications. You all know synovial osteochondromatosis connected to the joint when you see calcifications or ossifications. And in pigmented filonodular synovitis, when you do X-ray, but often when you do CT scan, you will see calcifications and dense areas with iron content. Calcifications can also be found on ultrasound or on plain radiography in phlebolyts, and then you have the diagnosis of a hemangioma. This is the egg of Columbus. So you see, peripherally, it's hard, and in the center you have Columbus. And you can see this on X-ray. And the name of this lesion is a myositis ossificans. It's not a tumor, but it's a pseudotumor. So I have one recommendation. They will send patients to you, and you will perform an MRI, and you will see a lesion which is aggressive, lots of edema. You will think this is a sarcoma, I don't know the name, but they should resect it. You should be courageous, and you should do a plain radiography today, and maybe within 1 week. And if you see an eggshell calcification, you have the diagnosis. If you see nothing, please do CT scan. And the typical sign of myositis ossificans is peripheral ossification and a loosened center. So that's very important. Finally, we have the signal intensities on T1 and T2. In group 1, we have a high signal intensity on T1 and intermediate signal intensity on T2. And this is typical for a lipoma, which should be homogeneous, but you are allowed to have a few very thin strands of fibrous tissue. If you have low single intensity masses combined with fatty tissue, you have a liposarcoma. In lipoblastoma, which occurs in children, you also will have fatty components combined with low single intensity components. And a rare tumor is the soft tissue melanoma, clear cell sarcoma, which is brighter than a normal muscle. Group 2 is intermediate single intensity on T1 and high on T2. Here we have a mixed high and intermediate single intensity with low liquefaction area. Then you should think of a hematoma with methemoglobin. Hemangiomas can be a little bit higher than muscle on T1, and when you see again this bag of worms, you think of a hemangioma. Group 3 has a low single intensity on T1 and a high single intensity on T2, and that's an easy one here. Very low single intensity, very high in a ganglion cyst. Myxoid liposarcoma. How can we make a specific diagnosis? So there is lipo with a high single intensity on T1, and you have myxoid tissue. And myxoid tissue is very, very bright on T2 and shows a lot of enhancement. So in this way, I can make the diagnosis of a myxoid liposarcoma. In contrast, this lesion has a low single intensity on T1, very bright on T2, and is showing only a little bit of enhancement. That's a myxoma. And the other type of tumor with myxoid tissue is a myxofibrosarcoma, which is very large and often shows necrotic areas. And the last group is the low to intermediate single intensity on T1 and low single intensity on T2. Here we have again the desmoid or musculoaponeurotic fibromatosis, where you have these collagen fibers which have a very low single intensity. The active part of the tumor will show a high single intensity on T2. I will explain this here again. So in yellow, you see these cellular proliferating areas, and they will show low single intensity and very intense enhancement. And the green area, which is black on T1 and black on T2, is the dense collagen tissue, which is old tissue. PVNS has typical low single intensity on T1 and low single intensity on T2. And to make the diagnosis of PVNS, you should add a T2 gradient echo sequence, T2 star, which shows a blooming artifact due to the iron content of PVNS. The signs suggesting malignancy are a lesion larger than 3 centimeters, central necrosis, deep to the fascia, and invading the bone or neurovascular tissue. Many of these lesions are in the thigh or in the groin, and when you give dynamic contrast enhanced MRI, you will see inhomogeneous enhancement and a faster enhancement than muscle tissue. So finally, we will do the staging and the monitoring of therapy. You all know that MRI is the best technique to do the local staging, extension into the joints, extension into the bone and the muscles and soft tissues. Be careful, synovial sarcoma, for instance, will invade lymph nodes. Many other sarcomas will not invade lymph nodes. There's not so much additional value for PET, FDG PET, because it's not better and will not change patient management when you do compare it with MRI. Always look for the whole limb. Do a longitudinal sequence from one joint to the other joint to find skip metastasis. And usually you do longitudinal sequences, T1 before and after gadolinium, and axial slices, T1 proton density and after gadolinium. You should use gadolinium to differentiate necrotic areas from viable areas, to direct the biopsy towards the most active part of the tumor. Again, first MRI and then the biopsy. And finally, we have to do the monitoring of therapy. So when you have a patient who has been operated on, the rule is that every high single intensity mass on T2 is a recurrence until you prove it's not. And you should always add dynamic contrast enhanced MRI. So this is the scheme you should use. When you have on ultrasound a lesion, you send the patient to MRI, you do a T2 stir, and when you see a low single intensity mass, think of recurrence of fibromatosis or pigmented villonodular synovitis. When you see a high single intensity but with no mass, then it's probably reactive tissue or inflammation. When you have a high single intensity mass, please do dynamic MRI. The reactive tissue will have slow, moderate, and late enhancement. A seroma will have no enhancement, and a recurrence will have early and fast enhancement. So I have one example. Here we have a lesion which has been operated on, and we do the first follow-up. Here we are at month 9. You see, looks good, no problem at all. But the patient comes back at month 12, and we see a white mass, which is suspect. We perform dynamic contrast-enhanced MRI in this mass, and we see very high perfusion. So this is a recurrence. And this is an example of a large seroma with low signal intensity on T1, high on T2, after resection of this musculoaponeurotic fibromatosis. So the task is done. We have seen detection, diagnosis, staging of the lesion. And in conclusion, for soft tissue tumors, the best initial imaging technique is ultrasound. You can differentiate cyst from a mass. You can make the diagnosis of a hemangioma, nerve sheath tumor. Be careful with lipoma, especially when there is a lesion below the fascia. And you should do the tissue characterization with MRI, looking at age, location, multiplicity, morphologic signs, signal intensity on T1 and T2, and calcifications. And when you have that specific sign, you can make the diagnosis. And don't forget, first MR imaging and then a biopsy. Thank you for your attention.